You guys live.
All right, so Senate Health and Welfare, we are back. And we are taking a break from H91 and looking at H266 with some updates to language for consideration. I think our goal here is to consider whether we can include the language that Jen is bringing to us. And that some of them are agreed upon by interested parties, and another section is new. It's the white bag piece, but why don't we go ahead and present that?
Okay. Good morning, Jen Carvey from the Office of Legislative Counsel. Thanks for being flexible. This is H266. It's an act relating to 340B prescription drug pricing program. And this is two instances of amendment. So no changes to section 1, which was the piece that tries to prohibit pharmaceutical manufacturers from putting restrictions on use of contract pharmacies. This is making changes in section 2, the reporting on hospital participation in the 340B drug pricing program. And this is based on the recommendations from the Office of the Healthcare Advocate and VAS. They gave us some consensus recommendations. So first, in the reporting on participation in the program, this would designate the existing language we've looked at as subsection A and require that the hospitals submit to the Green Mountain Care Board in a form and manner prescribed by the board a report detailing the hospital's participation in the program during the previous fiscal year. Which we posted on the board's website and contain at least the following information. Subdivision 1 is entirely changed, or almost entirely changed. It would say that for prescription drugs that the hospital or any entity acting on behalf of the hospital obtained through the 340B program and dispensed or administered to patients during the previous calendar year, they would report the aggregated acquisition cost for all such prescription drugs and the aggregated payment amount that the hospital received for all such prescription drugs, with information reported separately for each of the following distribution channels: dispensed drugs from an in-house pharmacy, dispensed drugs from a contract pharmacy, administered drugs paid separately, and administered drugs paid by bundled payments. For administered drugs for which payment was bundled with payment for other services, which is what's being described in that last number 4 there, the hospital shall estimate the payment amount by comparing the actual acquisition cost for a drug to the wholesale acquisition cost for that drug.
The WAC and the ACT. Okay.
Then numbers 2 and 3 are not changed. So that's the aggregated payment amount the hospital made to contract pharmacies and the aggregated amount the hospital made to any other outside vendor for facilitating any part of its program. The strike number 4 on the number of claims for all prescription drugs the hospital obtained through the 340B program during the previous hospital fiscal year. That's really captured in number 1. And then number 4 changes the terminology from savings to revenue, which, as you may recall, the hospitals grudgingly agreed to do yesterday. 3 numbers, number 4 is number 5. And then in subsection B, this is that confidentiality language. So in addition to the vendor information required pursuant to subdivision A3, each hospital shall also provide to the board a list of the names of all vendors that managed, administered, or facilitated any aspect of the hospital's 340B program during the previous calendar year, along with a brief description of the work performed by each vendor. And the vendor information reported pursuant to this subsection would be exempt from public inspection, and copying under the Public Records Act be kept confidential, except that the board shall provide the information to the Office of the Healthcare Advocate, which shall not further disclose this confidential information. So I broke this out as a separate piece because all the rest of the information is supposed to be posted on the board's website. So in order to have this piece be completely outside of that public posting, we made it as its own subsection. So that is new section 2. And then the second instance of amendment would add a new section 4. And this would amend a provision of existing statute in Title 8.
So section 3 is untouched.
Section 3 is untouched. Section 3 is just the sunset on the reporting. So section 4 would amend some requirements relating to health insurers and pharmacy benefit managers. And the lead language in subsection B that was added a couple of years ago, that prohibits a health insurer or pharmacy benefit manager from, by contract, written policy, or written procedure, requiring that a pharmacy designated by the health insurer or pharmacy benefit manager dispense medication directly to a healthcare setting or healthcare professional to administer to a patient. This is what people refer to as white bagging. And it would repeal that prohibition, which would allow that to potentially be processed. Which I think is hospital, or that insurers can tell you more, but I think it's a cost containment measure from the insurer.
What are the implications of this? And we'll have to ask the folks who are in the room in terms of direct delivery of medications to patients who can't make it to the provider or the hospital.
I think this is, I mean, the specific idea here is whether a medication can be dispensed directly to a healthcare setting for the healthcare professional to administer to the patient. So an underpinning of that is that the patient can get to the provider for the medication to be administered. It's just where it is, where the medication is acquired from.
Right. Okay, and we've heard that there are significant savings to, that would come from this. I think the healthcare advocate had suggested that.
I'm sorry, are we talking white
White bagging.
Yeah, we are.
Thank you.
That's what that is.
What planet am I?
Yeah, we're right there. So I'm looking at you if you'd like to comment on that.
Mike Fisher, healthcare advocate. I don't have any specific information. I have just understood, I think in part from Blue Cross, about the costs of the white bagging prohibition. And given the significant financial pressures that we as a system are in right now, everyone is looking for ways to reduce the costs.
Can I ask you a question? This doesn't affect telehealth at all, does it? Telemedicine? Okay.
No, I don't. So,
Sherry, did you want to comment on this?
I would say that yes, our expectation is that we would be able to save money by procuring drugs for patients from cheaper settings.
Okay. So the question,
Are there significant savings?
Yeah.
well,
Right.
the question I've heard, the 50 million number somewhere. What that?
I'm not sure that was related to this.
No,
Yeah,
this-
I provided in a presentation.
Yeah, you did.
A few weeks ago, I can't remember exactly when, an estimate of the total cost we expect for white bagging and some savings.
Yeah,
Another alternative is because you're eliminating this language, we could potentially use it to negotiate lower prices at the hospitals rather than procure the drugs from a different vendor and have them administered at the hospital. So there's two alternatives here, but both would save money.
What do you want from
We
me?
want to save money, so.
sorry, I didn't miss the last part.
Yes, so this would allow a health insurance plan to either procure the drug from a less expensive vendor,
Yeah.
usually RPBM, and deliver it to the hospital for infusion for the patient, or negotiate a lower price with the hospital because we have this alternative.
And how can we ensure that it will be a lower price? Is there any way that we can do that?
I mean, that's not what this language does.
No, I know that doesn't say it,
Are
but
there
the
ways you
implication
could-
is it will be there, and that's what we're looking for. We're looking for that
Right,
goal.
and you're giving more negotiating
Yeah,
room for the insurers.
okay,
On
we'll
that piece.
we'll hold this thought here. I'm looking at anyone else around the room who would like to comment on this. Yes,
Jessica Askey for EDM Health Network. I would just say we instituted this a couple of years ago at the request of the hospitals because of you should hear from the hospitals directly, but I remember that it was because of the cost and the quality, the convenience and the quality of the
Yes.
medications when they're being delivered in the hospital, and that people have to bring the medications from outside of the hospital. Sometimes they are not at the temperature they need to be. There's not clarity about the procurement of them, and there was concerns. And that's what I remember, the reason that we did this in the first place. So
Right, so the savings go in both directions.
arguably.
Okay. Yeah, no, I remember that too. I remember the benefit to the patient, and patients don't always keep it in the fridge.
Right, this is not about the patient, that's the
No.
brown bagging.
Yeah.
Brown bagging is still prohibited in this section, so that hasn't
Okay, so
gone
we
away.
still
This-
have that protection.
We still have that, right, so that's, and brown bagging is where the medication is distributed to the patient, for the patient to bring to the healthcare setting for the provider to administer it. In this case, we're talking about dispensing medication directly to a healthcare setting. So white bagging versus brown bagging.
Question I have then, you might, so it's a question I think for the insurance company really is, if you're ordering it from a different vendor, are you getting the same medication that is prescribed by the physician? So we're not talking about changing the treatment.
No substitution.
There's not a substitution. I mean, that's important. Okay.
Presumably the cost saving that we have for within that language, is that cost savings there? Is that going to insurance? And what would guarantee that is passed on to consumers or patients?
Well, if the pass on, so yes, my understanding is that the reduction would be would be realized by the insurers as opposed to the hospitals. The pass through to the patient is what's looked at in the rate review, health insurance rate review process. So I think, given the current issues with Blue Cross, some of that may have to go toward restoring solvency and reducing premiums. And how that would balance out.
That's what this is about.
But yes, the idea here is to potentially make things cheaper for health insurance distribution.
You open one door, you close another. The teeter-totter goes this way and that way. Okay. Or seesaw.
I mean,
Go ahead, Mike.
correct me if I'm wrong, but this discussion of savings and revenue, I think often gets confusing. We're talking about, if the hospitals are providing the medications, in the white bag, if hospitals are providing the medications, the commercial payer still pays the commercial price. And so I think that's the
Yeah.
place where, now that ends up being a revenue for the hospitals. But the person who's paying for their premiums and paying for their deductibles is still footing the bill like as a commercial purchase.
Okay. Here's my suggestion on this one. What are your thoughts, committee, on the language that we have and that we heard from hospitals and a healthcare advocate yesterday on the agreement with that language? That I think we can say, okay, we're okay with that. My suggestion for the bill, with including the white bagging piece, is to come back to it on Tuesday, first thing. Let's just hope we don't have a big day on the floor, and consider the language for a vote, and we'll see where we go. Let's do that. Jen, thank you so much for putting this in. This is tough. This is a very difficult pill. No, to swallow, all of it. So difficult. We don't know where to go. Okay, we'll do that. Thank you so much. And we're gonna